The topic of Chapter 16 is the respiratory system. The term respiration includes ventilation or breathing, which is the mechanical process that moves air into and out of lungs. The term ventilation actually has a more general sense, which is it actually simply refers to the movement of a medium over a respiratory surface. So, for example, fish also ventilate because they move the medium, which is water, over their gills, which is the respiratory surface. Gas exchange between blood and the lungs and between blood and tissues is also part of respiration. It's part of getting oxygen to tissues and CO2 away from tissues that have been doing aerobic metabolism. And then finally, the term respiration is also used for the oxygen utilization by tissues to make ATP, and that's often referred to as cellular respiration. So we can divide ventilation into external respiration, which is going to be the ventilation and gas exchange in the lungs. And we can also consider internal respiration. This is the oxygen utilization and gas exchange within the tissues. Gas exchange occurs in the lungs via diffusion. Diffusion occurs very rapidly because the lungs have a very large surface area, and because the diffusion distance between the alveolar airspace, the alveolar are these tiny little sacs within the lung that contain air that you breathe in. So the diffusion distance between the alveolar air space and the blood plasma and the pulmonary capillaries is very short. The oxygen concentration in the lungs within this alveolar airspace is higher than that of the oxygen concentration within the pulmonary capillaries. Therefore, oxygen diffuses into the blood. Conversely, the CO2 concentration in the blood within the pulmonary capillaries is higher than the CO2 concentration within the alveolar airspace within these little air sacs. And so CO2 diffuses out of the blood and into the alveoli. Next, let's look at the pathway for air to reach these alveoli. Air first enters in the nasal cavity, shown here, and from there it can move into the pharynx. And during exercise, a person can open their mouth, and air, of course, can enter through the oral cavity, and the oral cavity also connects with the pharynx. So air enters into this common tube called the pharynx. Now, the pharynx is also a common tube in the sense that in addition to air, food will also pass through the pharynx. On the way to the stomach, food, of course, would go through the esophagus, which is located behind the trachea. For air, air would enter into the larynx next, which sits atop the trachea within the neck. The larynx is also referred to as the voice box. It contains the vocal cords, and so the vocal cords are, of course, used for making vocalizations as air passes out during an exhalation. So the glottis is part of the larynx that contains the vocal cords and the opening between them. So that's the glottis. It's not shown on here, but there's the glottis here. And actually, there's another bit of tissue here called the epiglottis. The epiglottis helps to prevent food from going down the trachea. So when a person swallows food, a bolus of food, which is a small ball of food, the larynx actually moves up and the epiglottis down, and this prevents food from going into the trachea. And so food would go towards the esophagus. So below the larynx begins the trachea. The trachea is cartilaginous, has these cartilaginous rings, which you can see here in this picture. And then from there on, we go to the right and left primary bronchi, which are these major tubes. From there, you go into small divisions. You have secondary bronchi, tertiary bronchi, and so forth. Finally, ending at the terminal bronchioles. The terminal bronchioles then lead to what was referred to as the respiratory zone, the area in which diffusion of gases actually occurs. And so the next level is the respiratory bronchioles. I'll show a picture of that in a subsequent slide. And so these do allow for some diffusion because the respiratory bronchioles do in fact have some alveoli on the attached to them. And then finally, there at the very ends of these respiratory bronchioles, are these groups or clusters of alveoli, which are referred to as terminal alveolar sacs. And the alveoli are designed for diffusion of gas. They have very thin layer of epithelium and so forth within them, which I'll show you in a subsequent slide. And so this is where a lot of the gas diffusion occurs. In this picture here, we can see the trachea, which divides into the two primary bronchi. And then as you can see, there are further and further, smaller and smaller divisions. In this case, we're seeing all the divisions up to the level of the terminal bronchioles. In this picture, we can see the larynx and how it sits atop the trachea. And so this thyroid cartilage is what's also known as the laryngeal prominence or Adam's apple in males, because it sticks out enough that it's quite obvious and easy to see. Note again that we can see very clearly here these cartilaginous rings. For example, the larynx has a cartilaginous ring here, and then the trachea has a number of cartilaginous rings. And the purpose of these rings is to give strength to the trachea and the larynx, so that they don't collapse due to changes in air pressure as the person's breathing in. So they act a lot like the rings you would see on a hose for a vacuum cleaner. At the same time, the fact that they're rings rather than continuous means that the trachea is quite flexible. So it's strong but flexible. The vocal cords, which are also called the vocal folds, are two bands of smooth muscle tissue found in the larynx, which is also referred to as the voice box. And recall that the larynx sits atop the trachea within the neck. The vocal cords vibrate as one exhales, and this generates sound for the production of voice. And you can notice here in this picture the glottis. So the glottis, it really depends on who's defining it. Sometimes it's defined as the opening between the vocal cords, and sometimes the glottis is defined as encompassing not only the opening, but also the vocal cords and that portion of the larynx that surrounds the vocal cords. This diagram shows very nicely that the respiratory system can be anatomically divided into the conduction zone, which gets air to the respiratory zone, and then the respiratory zone, which is the site of gas exchange. So the conducting zone consists of the nose, the mouth, the pharynx, the larynx, and then as you can continue here with the trachea, the primary bronchi, the bronchioles, all the way down to the terminal bronchioles. From there, we transition into what are called the respiratory bronchioles, and this is we're now in the respiratory zone. And the respiratory bronchioles are considered to be respiratory because they have the occasional alveolus attached to their walls. And so this allows for some diffusion of gas across the walls of these respiratory bronchioles. The respiratory bronchioles then lead into alveolar ducts. You can see that these are essentially tube-like and they have many, many alveoli. And finally, this leads to terminal alveolar sacs. So the alveolar sacs are a group of alveoli. The conducting zone has a number of functions. First of all, it transports air into the lungs and to the alveoli where the diffusion of gas would occur. But other than that, it also is very importantly warms the air, humidifies the air, and filters the air, and cleans the air. So, for example, we have filters in the sense we have things like nose hairs that help filter out large particles. Within the conducting zone, there are cells that generate mucus. This mucus traps small particles, things like bacteria and dust. And then the cells that aren't generating mucus are covered with cilia. So per cell, about 300 cilia. And these are constantly moving in a wave-like fashion, and they move this mucus up away from the lungs. And this mucus is eventually either swallowed or you could, it could come out of your body. This is very important for keeping the tubes essentially clean within this conducting zone. Additionally, voice production in the larynx is very important as air passes over the vocal cords. A few other things to note: the mucus moving along by the beating of the cilia is referred to as the mucociliary escalator. And so that, of course, as I said, brings the mucus up to the pharynx where it can be cleared by swallowing or by expectorating. And this is called mucociliary clearance. Now, there are certain disease states that affect this escalator. In cystic fibrosis, the mucociliary escalator fails to function properly. And this is because in patients that have cystic fibrosis, there's abnormal mucus. It's too thick for the cilia to properly clear. Additionally, cigarette smoking can damage the cilia and reduce the mucociliary clearance. So diffusion occurs primarily at the alveoli. These are air sacs in the lungs where gas exchange occurs. They provide a very large surface area, about 760 square feet in an adult. And this, of course, increases the diffusion rate. Each alveolus has a wall that's only one cell layer thick, and these cells are squamous, meaning they're very thin. And the alveoli form clusters called sacs at the ends of respiratory bronchioles. So, for example, here we can see, if we zoom in on a little section of the lung, we can see a terminal bronchiole, which then divides into respiratory bronchioles. We can identify these bronchioles as being respiratory because they have the occasional alveolus attached to their walls. And then finally, we end at an alveolar sac consisting of a group of alveoli. So within these sacs, it's not shown here, but they're actually small air passages between neighboring alveoli. And this does allow for some movement of gas between neighboring alveoli. Within an alveolus, there are two types of cells. Type 1 is the predominant cell type. These are the thin epithelial cells. So, for example, here we can see a picture of a type 1 alveolar cell. So diffusion of gas occurs primarily across these type 1 alveolar cells. And so within the lungs, there's very little interstitial space. There is some, but often there's a fused basement membrane between an type 1 alveolar cell and the endothelial cells of a pulmonary capillary. In other words, they just have a single layer basement membrane, which is shown here. And so this allows for a very short distance for gas diffusion. And that, of course, helps with gas diffusion. Now, within the alveolus, there's also the type 2 alveolar cells. These cells are incredibly important. They secrete pulmonary surfactant. We'll talk more about what surfactant does. But I should mention now that within the alveolus, there's a thin layer of fluid, and it would have some of the surfactant in it. This thin layer of fluid is very important because in order for gas to diffuse from the air within the alveolus, within this alveolar airspace, and into the type 1 alveolar cells, it needs to first dissolve into the water. So there needs to be a very thin layer. So your lungs are very moist because of this. You have this thin layer of water. Now, the type 2 alveolar cells also reabsorb sodium and water. So occasionally there may be too much water in an alveolus, and that's bad. So they reabsorb the water, and the water then ends up in the interstitial space. So this prevents the buildup of water, which would be bad because, of course, an increase, if you can imagine what would happen if there was a lot of water, this would increase the diffusion distance, and that would decrease the diffusion rate. The rate of diffusion, according to Fick's law of diffusion, decreases linearly with the thickness of the membrane, separating two regions. Finally, there are also macrophages within each alveolus. These cells engulf foreign particles such as bacteria and dust. And unfortunately, cigarette smoking diminishes the cleaning action of these alveolar macrophages. These are two electron micrographs showing the structure of the lung in high magnification. Here we can see a bronchiole. There are small sacs, which are shown here, which are the individual alveoli. And then we have a blood vessel here. In this other electron micrograph, you can see what's presumably a bronchiole, and then you can see the alveoli in greater detail. So for example, here, it appears that there are a number of alveoli that are sort of combined together. So this is presumably an alveolar sac. The major inspiratory muscle is the diaphragm. It's a dome-shaped sheet of skeletal muscle that separates the thoracic and abdominal cavities. Within the thoracic cavity, the heart, the trachea, the esophagus, and thymus all reside within the central mediastinum. The lungs are surrounded by two membranes referred to as the parietal pleura and the visceral pleura. The parietal pleura lines the thoracic wall. So for example, in this diagram, it's shown in green. So that's the parietal pleura. You can see it encircles the lung, and it's attached to the wall of the thorax. And then there's the visceral pleura. The visceral pleura is the inner membrane here, shown in blue. Notice that these are continuous. So for example, it's really, the lungs can be thought of as like this hand pushing into a balloon. And so the inner part of the balloon would be the visceral pleura, and the outer part of the balloon would be the parietal pleura. So it's one continuous membrane, although it forms this double layered sac because of the way the lungs reside within this cavity within the pleura. So normally the parietal and visceral pleura are pushed together and there's just a very thin fluid-filled space between them called the intrapleural space. These pleural are very important, and the fact that there's a thin layer of fluid between them is extremely important. What it does is it allows for the lungs to move within this sac, and so the lungs can move sort of freely without rubbing up against other things within the thorax, such as the heart and other internal organs. Because of course the lungs are constantly expanding and contracting. Additionally, and we'll go into this more in greater detail later, but within this pleural space, the pressure is actually lower than atmospheric. And this allows for the lungs to essentially be sort of stuck to the inner wall of the thorax. And so as the thorax expands and contracts, the lungs also expand and contract. And therefore, this helps to prevent the lungs. There's a tendency for the lungs to collapse inwards, and this prevents the collapse of the lungs. So this idea of a subatmospheric pressure in the interpleural space is always a bit confusing. Here's how it arises. The lungs have a tendency to collapse inwards. At the same time, the ribs of the thoracic cavity have a tendency to expand outwards. And so you can think of this interpleural space being trapped between these two forces. So there's something pulling inwards and there's something pulling outwards. And because of that, they generate a kind of a negative or lower than atmospheric pressure between those two forces. So this is exactly the same principle on how a suction cup works. You take a suction cup, you push it against a wall, and then you pull on it. And now you've created an area with a lower pressure than the atmospheric pressure. And so that's a subatmospheric pressure. And that's exactly what's happening here between these opposing forces of the inward collapse of the lungs and the outward movement of the ribs. In these x-rays of the thoracic cavity, we can see the lungs as being clear spaces. We can see the heart, and we can see where the diaphragm presumably is. Below the diaphragm would be the abdominal organs, and those are showing up as more dense, or which shows up as white in the X-ray. Same thing in the male. This is presumably the diaphragm here. Here's the heart, and then the lungs are quite clear because they're less dense. We're next going to look at physical laws that govern ventilation. Airflow depends on the pressure difference between the two ends of an airway. So for example, here in this picture, we have P1 and P2. So the difference is delta P, which is P1 minus P2. Here we're assuming that pressure in P1 is higher than that of P2. It also depends on the resistance of the airways, and air will always move from an area of higher pressure to lower pressure. There are different types of pressure. For example, there's atmospheric pressure. That's the pressure outside of the body. Within the lungs, there's intrapulmonary pressure, and this is also referred to as intraalveolar pressure. This is the pressure within the lungs. So if we look at inspiration, during inspiration, the thoracic cavity expands in volume, and we can see how that occurs. So the diaphragm contracts during inhalation. And remember, it's dome-shaped, but it's a flat sheet, so it tends to flatten out a little bit. And so that lowers the bottom of the thoracic cavity, and that increases the volume within the thoracic cavity. Now, recall that the lungs are sort of, in a sense, stuck to the sides of the thoracic cavity because of the negative intrapleural pressure. And so as the thoracic cavity expands, the lungs also expand. This expansion leads to an increase in the volume of the lungs. An increase in volume leads to a decrease in pressure within the lungs. And so the pressure within the lungs will end up during inspiration being about 1 to 3 torr lower than the atmospheric pressure. Torr is the same unit as millimeters of mercury. Due to this pressure difference, air will enter during inspiration. During expiration, we have the opposite. The diaphragm relaxes, and as it relaxes, it turns back into more of a dome shape, and the thoracic cavity volume goes down. The lungs collapse inward a bit, and there's an increase. And with this decrease in volume, there's an increase in pressure. And this now the pressure within the lungs, the intrapulmonary or intraalveolar pressure, is higher than that of the atmospheric pressure. And now air will flow out. As I mentioned in the previous slide, during inspiration or inhalation, the intrapulmonary pressure is lower than the atmospheric pressure. When the pressure is below that of the atmosphere, it's called subatmospheric, or sometimes it's referred to as negative pressure. So generally during inspiration, for a person who's just quietly breathing at rest, this pressure would be negative 3 millimeters of mercury. Now during the inspiration, that pressure isn't constant. By the very end of inspiration, once you've inspired as much as you can, that pressure drops to 0. So there's a moment in which there's no further movement of air in or out of the lungs because there's no pressure difference. So at the end of that inspiration, then expiration may begin. So the diaphragm relaxes, and it goes back into its more like a dome-shaped conformation where it's relaxes upwards essentially. And so this occurs during expiration. And so due to the reduction in the volume of the thoracic cavity, the intrapulmonary pressure becomes greater than that of atmospheric pressure, and it's generally going to be about 3 millimeters of mercury higher than atmospheric pressure. And again, with expiration, the pressure isn't completely constant. By the end of expiration, the diaphragm's completely relaxed, and the pressure becomes 0. The difference between the intrapulmonary pressure and the atmospheric pressure becomes 0. And yet again, there's a point in which there's no movement of air at that point. And then you go back, the cycle begins again next with inspiration. And now it's you have the contraction of the diaphragm, and therefore you get a negative or subatmospheric pressure being generated again. Recall that there's also the interpleural pressure. That's the pressure within the interpleural space between the parietal and visceral pleura. And this space, again, contains a thin layer of fluid that serves as a lubricant. And you can see that here in this picture here. So here's the interpleural space. Of course, it's exaggerated. It's not really that thick of a space in reality. The interpleural pressure is lower than the intrapulmonary pressure during both inspiration and expiration. And there's another type of pressure, which is the transpulmonary pressure. This is the difference between the intrapulmonary pressure and the interpleural pressure. So let's take a look at this diagram. So here we have a person who's this person is between breaths, such there's no difference between the intrapulmonary pressure, which is also called the intraalveolar pressure, and the atmospheric pressure. So it's 760 millimeters of mercury. Okay, so that's the intrapulmonary pressure. And then if we look here, we have the intrapleural pressure, which is 756 millimeters of mercury. So it's 4 millimeters of mercury less. So to find the transpulmonary pressure, it's going to be the difference between the intrapulmonary pressure and the interpleural pressure. So we take the intrapulmonary pressure and subtract the intrapleural pressure. And so we get the intrapleural pressure is always lower than the intrapulmonary pressure, so we're always going to get a positive value. So we're getting a positive value of 4 millimeters of mercury. And so it turns out you always have a transpulmonary pressure that will be positive. And this represents the fact that this intrapleural pressure is always lower than the intrapulmonary pressure. And the reason you have this pressure, again, we've talked about the lungs collapsing inward and the ribs tending to recoil outwards. That causes the intrapleural pressure to be negative with respect to the intrapulmonary pressure. But so this transpulmonary pressure is very important because it keeps the lungs, it's the force that keeps the lungs against the thoracic wall. And so as the thoracic walls expand, this allows the lungs to also expand. As the thoracic walls collapse inwards during expiration, then the lungs collapse together with them. So they're sort of tied together via this transpulmonary pressure. So far, we've always expressed pressure in units of millimeters of mercury, which is the same thing as torr. Pressure may also be expressed using centimeters of water as a unit instead of millimeters of mercury. And here's the conversion factor. 1 centimeter of water equals 0.74 millimeters of mercury. So if we look at some of these values during inspiration, the intrapulmonary pressure is -1 centimeter of water. This is relative to atmospheric, below atmospheric. During expiration, it's +1 centimeter of water above atmospheric pressure. Note that during inspiration, the intrapleural pressure is negative. It's -8 centimeters of water. During expiration, it's still negative, but not as negative. It's -5. So note that the intrapleural pressure, as we'd expect, is always lower than the intrapulmonary pressure. And because of that, due to the way we calculate the transpulmonary pressure, the transpulmonary pressure is always positive. And so during inspiration, it's +7 centimeters of water, and during expiration, it's +6 centimeters of water. In order to understand inspiration and expiration, we need to understand how lung volume affects the pressure within the lungs, the intrapulmonary pressure. And one way to do this is using Boyle's law. Boyle's law states that the pressure of a gas is inversely proportional to its volume. This means an increase in lung volume during inspiration decreases the intrapulmonary pressure to subatmospheric levels. This causes air to go in. A decrease in lung volume during expiration increases the intrapulmonary pressure above atmospheric levels, and air goes out. In order to understand lung function, there are two terms we need to understand. The first is compliance. This is the ability of a hollow organ or vessel to distend and increase volume with increasing transmural pressure. So compliance is equal to delta V, change in volume, over change in pressure. So for example, you can imagine applying a certain amount of pressure to a blood vessel and then measuring the change in volume. The larger the change in volume for a given pressure, the higher the compliance. Low arterial compliance is an important cardiovascular risk factor. So for example, as people get older, the aorta and other major arteries become less compliant, and this can lead to a higher systolic blood pressure. Elastance is usually a measure of the tendency of a hollow organ or vessel, for example, lungs, urinary bladder, gallbladder, to recoil towards its original dimensions upon the removal of the distending or compressing force. So again, we can use the example of the aorta or other major arteries. During the ejection phase, you have blood ending up in the elastic arteries. Because they're compliant, they increase in diameter, but they also show elastance. They have these elastin protein fibers within their walls, and so they recoil during diastole. And so this elastic recoil tends to squeeze the blood and increase the pressure during diastole. So you can see here these are opposite terms. They're different terms. Compliance and elastance, they have different meanings, and yet the same organ can have both properties. The aorta and major arteries are both compliant, meaning that they can increase in diameter, allowing for change in volume within the vessel, but they also have elastic recoil, which is measured as the elastance. The idea of compliance can be applied to the lungs. The lungs can expand when stretched, and we can define the change in lung volume per change in transpulmonary pressure as C equals delta V over delta P. The ease with which the lungs expands under pressure is a measure of the compliance. Now, there are certain disease states that will lead to a change in lung compliance. Compliance is reduced by factors that produce a resistance to distension, such as infiltration of connective tissue proteins and this occurs in the disease state called pulmonary fibrosis. So for example, if we look at this picture here, to the left we have normal lung. If we zoom in, we can see the terminal alveolar sac with normal alveoli. Now, in pulmonary fibrosis, there are large areas of scarring or fibrosis within these alveolar sacs. There's also irregular thickening of the tissue between the alveoli. Now, this scarring and thickening makes the lung less compliant. And so if we look at a graph of this, let's take a look at here's with an increase in transpulmonary pressure, we see an increase in lung volume. So this is the normal curve. So that shows the normal compliance. But now with the diseased lung with pulmonary fibrosis, with an increase in pulmonary pressure, the increase in lung volume is not as great. And so again, compliance is defined as change in volume over change in pressure. So for a given pressure change, there's less of a volume change, and therefore the lungs are less compliant. And this decrease in compliance makes it much more difficult to breathe. The diaphragm and the other muscles that are involved in inspiration and expiration have to work a lot harder. Elasticity is another very important property of the lungs. The lungs tend to return to their initial size after being stretched, which is elastic recoil. So you can see in this diagram, there's an internal force, which is this elastic recoil tending to make the lungs collapse. Now, they don't collapse because the lungs are stuck to the thoracic wall because of that negative intrapleural pressure, that subatmospheric intrapleural pressure that we talked about earlier. Therefore, the lungs are always under elastic tension. They're tending to pull inwards. At the same time, I'm not showing it, but the rib cage is tending to expand outwards. And so this creates this negative intrapleural pressure. This tension increases during inspiration and is reduced during expiration. We've just established that having very low compliance is bad because it's difficult to inspire. For a given pressure change that's generated by the inspiratory muscles, such as the diaphragm, there's not as much of a lung volume change. And so that makes it more difficult to inhale air, bring new fresh air into the alveolar airspace. So for example, here we see the normal person for a certain transpulmonary pressure, there's going to be an increase in lung volume that becomes greater and greater. Now, the opposite is also true. Having lungs that are too compliant is also a problem. So let's take a look at emphysema. With someone who has emphysema, there's a breakdown in the alveolar walls. And so the alveoli actually, instead of having individual sacs, often combine into a big, larger sac. And there's also less elastic protein, such as elastin within the lungs, and the alveoli are misshapen. So there's been a general decrease in elasticity within the lungs, so there's less elastic recoil. But the lungs are very compliant. In other words, if you apply the same transpulmonary pressure as you would to a normal lung, you get a much bigger change in lung volume. So the lungs are able to inflate more. But at the same time, there's fewer of these alveolar sacs, and so there's actually less surface area. So there actually hasn't been any gain in terms of getting oxygen diffusing into the blood, into the pulmonary capillaries. At the same time, that you now have a loss of this elastic recoil. So there's less elastic recoil. And normally when someone's doing quiet breathing, that means they're at rest and they're just breathing normally. This elastic recoil is very important because you inspire mostly with the diaphragm descending as it contracts. And at the same time, there might be some expansion of the rib cage, which helps to increase the volume of the thoracic cavity, which increases the lung volume. But then when you're just at rest and you're not actively exercising, then exhalation is mostly a passive phenomenon that involves elastic recoil. And a lot of the elastic recoil is provided by the lung itself. In a nice healthy lung, you have a nice elastic recoil because it tends to want to collapse back inwards. So these people with emphysema don't have that, and it means for them, they now have to exert much more muscular effort. We do have expiratory muscles that help to collapse the lung, the thoracic cavity. But now, so then these muscles now have to be active during expiration. And so this is very difficult and very fatiguing for someone who has emphysema. Okay, another physical property we need to understand is that of surface tension. Recall that the alveoli have a thin layer of fluid lining. This fluid is extremely important because oxygen diffuses from the alveolar airspace into this thin film, and then from there it diffuses through the epithelial cells that line the alveoli, and then into the interstitial fluid, and then through the endothelial cells of the pulmonary capillaries and into the blood plasma. So we need to have this thin layer of fluid. In fact, that layer of fluid is regulated. There can't be too little or too much. And so the body tightly regulates that. But there's a general problem with having fluid within these tiny little alveoli, which is that water tends to generate surface tension. And so that would make anything that has a lot of fluid tend to collapse into a ball of fluid. So surface tension occurs in water because of hydrogen bonding. Recall that oxygen has a partial negative charge because of electronegativity of oxygen, and the hydrogen within water has a partial positive charge. And because of this, the water molecules tend to cling to one another. Now, for a molecule of water that's deep within a fluid, within the bulk of a liquid, there's not really any problem because there's water all around it, so it's being pulled by other water molecules equally in every direction. For a water molecule at the surface, though, it's being pulled unequally. There's pull laterally and pull down back into the bulk fluid, but there's no pull upwards towards the interface where there's air. And so because of this reason, you get a sort of skin-like surface tension on the outside of the water. And this tends to make water bead up and pull together. And so again, for something as small as an alveolus, this having a lot of water in it would tend to collapse the alveolus inwards on itself. The consequences of this surface tension is that the alveolus will resist distension. So normally an alveolus needs to be able to distend or expand during inspiration, but if there's a lot of surface tension, it'll be very difficult to inspire air because of this resistance. The second thing is the surface tension will tend to collapse the alveolus, and this can raise the pressure within the alveolar air. And in fact, it could be so extreme that the alveolus would completely collapse and not open up at all, and then it would be non-functioning. In order to understand the effects of surface tension and the physical dimensions of something like an alveolus, we need to apply the law of Laplace. According to this law, pressure is directly proportional to surface tension and inversely proportional to the radius of the alveolus. So we could take the example here. We have two, and this is really poorly done by the artist, but they're showing an alveolar sac as if all the alveolar have collapsed together. But let's just imagine these are two different alveoli that happen to be different sizes. So there's a small one and there's a large one. So the small one has a radius of 1, the larger one has a radius of 2, and the units don't really matter here. We're just looking at the relative difference. So according to the law of Laplace, the pressure equals 2 multiplied by the surface tension divided by the radius. So for this one that has a radius of 2, we have 2 multiplied by t over 2, so pressure is equal to t. For this one over here, we have 2 multiplied by t, and then we're dividing by the radius, which is 1. And so we have 2t. So what we're finding is that the pressure is double in this alveolus that has a smaller diameter compared to the one that has a larger diameter. And so this one that has the smaller radius would have a larger tendency to collapse compared to the other one. And in fact, what they're showing you here is it will tend to collapse, and this may actually push air into the other one. Here's a video on YouTube showing an experiment. And we can ask the question, what will happen if air is allowed to move between these two soap bubbles? The answer is that the greater pressure in the smaller bubble will cause it to empty its air into the larger one. This gives rise to a new question, which is what prevents a small alveolus from emptying its air into a larger alveolus? In other words, why don't all the small alveoli in the lungs collapse? The answer is that the collapse of alveoli is prevented by secretions called surfactants. Surfactants are surface active agents. In the lung, these surfactants are a mixture of phospholipids and hydrophobic proteins. Recall that phospholipids are amphipathic molecules. They are both hydrophilic and hydrophobic. So, for example, a phospholipid has a head, which is hydrophilic, and it has hydrocarbon tails, which are hydrophobic. So the way those surfactants work is they become interspersed between water molecules at the water-air interface, and this reduces the number of hydrogen bonds between the water molecules near the surface of the fluid. So you can see that here in this diagram. There are now surfactant molecules, and these tend to aggregate towards the surface, and the reason is because of their amphipathic nature. They tend to like to associate with the water because they have hydrophilic heads, but they have hydrocarbon tails that are hydrophobic. So those hydrocarbon tails don't like to associate with water. And one way they can get away from water is by sticking out into the air. And so you've reduced the number of water molecules right at the surface by having surfactant molecules taking up space. and therefore that reduces hydrogen bonding laterally. So this reduces the density of water molecules at the air interface, and that's critical. But the question now arises, well, okay, so you've now reduced the number of water molecules, but we're showing these surfactant molecules as also having interactions laterally and down into the bulk of the fluid. So why don't they cause surface tension? Well, it turns out, recall that they have these hydrophobic tails. So there's actually an upward force because the hydrophobic tails are repulsed by water. And so they tend to want to pull the molecule upwards. So now you have a more equal distribution of force in every direction, and therefore you don't develop surface tension. Within your lungs, you have type 2 alveolar cells, one of which is shown here. It secretes surfactant, and this reduces the surface tension within an alveolus, and this prevents the collapse of the alveolus. And so this is functionally quite important because if you didn't have this, say you would expire air, your alveoli would tend to collapse almost completely, and you wouldn't have much air remaining within your lungs. So having a surfactant means this inward collapsing force is not nearly as great, and therefore you can have residual volume of air remaining in the lungs after exhalation. Back in the 1950s, a very high number of infants died every year of respiratory distress syndrome. The number is about 10,000 per year. The reason for this syndrome is because production of surfactant begins late in fetal life. Therefore, premature babies would be born with a high risk for alveolar collapse. Nowadays, we can treat these infants. They can be mechanically ventilated, and exogenous surfactant can be applied. And so now they have a very high rate of survival. And eventually, as the infant matures postnatally, they're able to start generating their own surfactant, and then respiration becomes easier for them. A similar problem may occur in adults, and this is caused by septic shock. People with septic shock may develop acute respiratory distress syndrome, or ARDS. And in this syndrome, inflammation causes increased permeability of the capillary endothelium and the alveolar epithelium. This increased permeability allows proteins and water to enter the interstitial space and into the lumina of the alveoli. The surface tension created by this fluid in the alveoli reduces lung compliance, and this makes it very difficult to breathe. And the result then can be hypoxemia, or low blood oxygen levels. Unfortunately, this disease is not treatable with surfactant. There is a disease state that gives us a very good insight into just how important the pleural space is and keeping net subatmospheric intrapleural pressure is. This disease is called pneumothorax, or it's also referred to as a collapsed lung. This occurs when all or part of a lung collapses or caves inward. And this occurs when air gets into the area between the lung and the chest wall. And so this area is this intrapleural space. In a pneumothorax, air enters the pleural space, raising the intrapleural pressure so that the pressure difference keeping the lung against the chest wall is eliminated. Recall that the intrapleural pressure is normally subatmospheric, and that acts as almost like kind of a glue that keeps the lung up against the chest wall. And so the lung then expands with the chest wall expanding, and the lung contracts with the chest wall contracting. And so what happens when this intrapleural pressure becomes the same as atmospheric pressure is that the lung then collapses due to its intrinsic elastic recoil. There's essentially two ways a pneumothorax can occur. One is to have air leak into that pleural space by leaking out of the lung. So it can be internal. So that, for example, a puncture from a broken rib or a lung disorder such as COPD or cystic fibrosis or the rupture of a lung blister can lead to air entering from the lung into the intrapleural space. The other possibility is air can enter from outside of the chest. So in other words, there can be an open chest wound that will allow air into the pleural space. And therefore, again, the intrapleural pressure will become atmospheric and then the lung will collapse. Fortunately, each lung is in a separate pleural compartment, so pneumothorax usually occurs in only one lung. And this is fantastic because this allows a person to get to the hospital and begin treatment. And usually when a person's at rest, breathing with just one lung is more than enough to get the oxygen that they need until the second lung is treated.